Hi, everybody. I'm just going to give it another 30 seconds or so as people are filtering in. If anyone wants to say hello in the chat, let us know where you're joining us from. That would be great. Barrie, Bancroft, London, Toronto. Wow, St. John's, Newfoundland. Hamilton, Chatham, Scarborough. What time is it now? Is it okay? I have 1 minute after 7. So maybe I'll start and we'll sort of go through some of the preliminaries, and more people will be filtering in, I'm sure. Welcome everyone. Thank you so much for joining us. My name is Sarah Clark. I'm MetaPhi's knowledge broker. I'm filling in for our normal conference, or excuse me, webinar moderator, Jennifer Wyman. She will be back next month, don't worry. But I'm very, very happy to be here introducing our second session. So I will just start with our MetaPhi land acknowledgement, and I, invite everyone to reflect on where you're joining us from. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of MetaPhi and our partners takes place on traditional territories of the indigenous nations who have lived on these lands since time immemorial. MetaPhi is located in Toronto on the ancestral homelands of the Huron-Wendat, the Anishinaabe, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons. And this is Dish with One Spoon Treaty Territory. We at MetaPhi are committed to reconciliation, and we recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors, and we invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So before I introduce our speaker for the evening, I'm just going to give a couple of housekeeping notes. Please share all of your comments and questions. Please use the chat box for any questions that you would like to have our speaker address at the end of the talk. You can also raise your hand while the speaker is talking, and if you raise your hand during the presentation, I'm going to let Larisa get to the end of her slide, and then I will call on anyone who has their hand raised. So don't feel obligated, but that is an option. Or you can, we will have 30 minutes at the end of the talk to dedicate to back and forth. And this session has been accredited for the College of Family Physicians of Canada and for the Royal College of Physicians and Surgeons of Canada, Section 1. And a session evaluation will be circulated following the webinar for your completion. It will both show up on your screen after you close down Zoom. Lori is going to drop it in the chat, and you will get an email with it tomorrow. So please, if you miss it, not to worry. So I'm going to stop my sharing here, and I'm going to introduce our speaker. We're very fortunate to have with us today Dr. Larisa Eibisch, a family physician passionate about supporting marginalized and vulnerable populations, particularly those struggling with poverty, addictions, and mental illness. Appreciating that drug use disorders disproportionately affect society's poorest people and communities, Larisa now practices integrative addictions and family medicine at the Sherbourne Health, a transformative community leader in primary care and programming, and focused addictions care at Coderic's Medical Clinic, both in the Greater Toronto area. To expand her reach beyond the urban setting, Larisa provides addictions care for North Spirit Lake First Nation, operating their Suboxone program remotely and in person since 2019. As part of OCFP's Poverty Committee, Larisa was instrumental in the development of a continuing professional development workshop entitled Treating Poverty, elements of which will feature in today's presentation. And now I will hand it over to Larisa to present her talk, which is entitled Treating Addiction Means Treating Poverty. Larisa, thank you so much for being with us today.
Thanks, Sarah. I'm going to share my screen now. Oops. Maybe I should start at the beginning. All right. Okay. Sorry, guys, for the little pause there. Thank you so much for the introduction and for inviting me to speak to this group. I know many people in the audience today, and I'm also very grateful for your participation and your support. So I'm very excited to talk to you about a concept that is near and dear to my heart and factors into every aspect of my day-to-day work as a family physician, as an addictions physician, and working with an Indigenous community in the North. Wanted to really give some credit where credit is due. So some of the original content from this presentation comes from the work that I did many years ago with the Ontario College Family Physicians Poverty Committee, which has been since disbanded, but elements live on through the OCFP website and through continuing effective practice. So I do encourage all of you to take a look at these websites and also section 5 of the recently published 2021 CAMH publication, Opioid Agonist Therapy, Prescriber's Guide to Treatment. There was several sections that outlined social determinants of health, including the one that I authored on poverty. So apart from that, I have no potential conflicts of interest. I do some work with Indivior as a speaker, but that does not contribute to today's presentation. No mitigating potential bias to disclose as well. So today's talk is going to be 3 parts. We're going to start by talking a bit of economics, and I'll be full disclosure here, I'm not an economist, but I have learned a lot in my work as a family physician. We're going to review how income intersects with other social determinants of health to impact health. We're then going to look at how determinants like income influence health, both our risk of developing substance use disorders and addictions health outcomes. And then lastly, and most importantly, in my opinion, we're going to go over an approach that as clinicians, you and we can all implement in day-to-day practice, and one that can make a real difference in how our patients are experiencing poverty. Now, this is called the poverty tool, and it's a simple approach that easily fits within a typical 10 to 15-minute appointment. So let's jump in and get started with the social determinants of health. A largely held assumption, by many, lay people, physicians, clinicians alike, is that health is primarily influenced by personal choice and our access to healthcare. However, there is growing awareness that really what shapes the health of Canadians is not medical treatments or lifestyle choices, but rather the conditions in which we live. As healthcare providers, it can seem overwhelming to consider how important these factors are and yet know that we really have no control over how they shape the health of our patients. Yet we can become aware of their influence on our patients' beliefs and actions, and then incorporate this knowledge into our treatment plans. So how big is this impact? Well, the Canadian Institute of Advanced Research estimates that social factors have a larger influence on our health than even our healthcare system. As you can see here, 50% is your life. And in a position statement on health equity, the Canadian Medical Association states that any action to improve health must address the social determinants of health and their impact on our lives. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. So really, these include a broad range of personal, social, economic, and environmental factors, which both individually and collectively influence our population health. And when unequally distributed, they can lead to significant health inequity. This graphic is an oldie but a goodie. The authors, Dahlgren and Whitehead, really layered the various social determinants of health as they confer influence on health. So you can see at the center, the individual is positioned right there with their given gene set. The next layer, so to speak, includes those personal lifestyle factor choices, which we kind of naturally look to as primary health drivers. This is then followed by our social and community networks, and the presence or absence of which can really impact a person's support system. As we move up, we see that living conditions or structural factors have a much greater impact: income, housing, employment, education. And then lastly, the broader influence of cultural, political, and environmental conditions, which all these factors affect their influence. So I was kind of thinking of an example that has recently come into play in my practice. So imagine an individual with their given gene set, and this individual identifies as queer or non-binary. So to manage their gender dysphoria and associated social anxiety, our patient has access to and consumes excess alcohol. So that's in that individual lifestyle factors. And then in order to seek medical support for their transitioning, our client has moved away from their home community to a larger city center and away from a network of close family friends. And that leaves them lonely and isolated. And then despite completing post-secondary training in their chosen field of trade as a plumber, they've been unable to secure gainful employment and as such are left really seeking with poor income, unable to afford housing and living in shelter. And then to finally figure out the last piece, one of the drivers for their unemployment is the lack of acceptance of gender issues amongst the trades. And this has made seeking and sustaining work a scary and unsafe process. So you can see that there's an interconnected nature here of these factors, and that's called intersectionality. Applied to research, intersectionality explores the interaction of various social determinants of health and how they confer advantage or disadvantage to people. So going back to our previous example, social disadvantage owing to gender identity, low income, and homelessness really increases the risk of adverse health outcomes in our patient. So I'm going to turn to more focused questions really on poverty. And that's noting that really income is in some ways the single most important factor which determines whether someone is healthy or not. But I'd like to get a sense of what poverty looks like to you. It looks different for everybody. I've been working with, frankly, homeless people for most of my career. And so poverty is often assumed. In fact, I sometimes struggle to really understand what it's like to have access to income and access to resources when so many of my clients do not have that. And poverty can often be hidden and manifest in different ways. Would you mind taking a minute to pop in the chat box what poverty looks like in your practice? And we'll keep an eye. I'm just going to look through it if as people are adding in. So far I'm seeing, oh, here we go. So Jennifer works with mostly homeless people. Gail has clients with no drug coverage. That's a real tough one, especially working with addictions, right? Unaffordable in terms of basic needs, can be detected sometimes, go to extremes to hide it. Oh, great. No access to internet and cell for accessing prescriptions for OAT, big time. Uninsured and undocumented people, absolutely. I once had a client, I was just thinking about the hidden aspect of poverty. At the Sherburne Health Center, we have a respite center on our floor, which supports clients who are marginally housed when they are requiring support discharge from hospital. And there's a client who is coming to us post breast biopsy, and she belonged to a small cultural community in the outskirts of Toronto. And when we asked where we could send her discharge summary to, she was very adamant that she didn't want her discharge summary sent to her family physician because her family doctor didn't know she was homeless, and she didn't want to lose face amongst her community of peers in that area. And so we realized just how much was missing. Like, think about the things that we could have done to support her had we known about her homelessness or her marginalized housing. Seeing a few more here. So homelessness in rural areas, no family physicians, absolutely banned from pharmacies and walk-in clinics. Phoneless, no shelter beds, not updated about taxes, not sleeping enough, not eating enough. unable to leave unsafe living conditions? Absolutely, Eric. We see that a lot. Domestic violence. People are stuck because they are codependent on their income. Food deserts in the inner city, right? Who can afford to shop at Rabba in Toronto? Homelessness, difficulty affording medications, food insecurity. Thanks everybody for participating. So let's talk a little bit more about the definition of poverty. So Stats Canada uses 3 benchmarks to estimate poverty. These are the low-income measure, the low-income cutoff, and the market basket measure. Now, these are strictly measures of low income that they don't at all encapsulate the ramifications of poverty. And the difference amongst these measures really underlies a lack of precision in defining it. But I want to look more closely at the low income measure, and because this is an internationally used measure to approximate poverty. And so what it does is it defines it defines a low income household as one whose income is less than half of the median income of all households. So take the median income of all households, divided by 2, anything below that is considered below the poverty line. So the most recent census data from Stats Canada for 2020 estimated that for a family of 4, 2 adults, 2 kids, the after-tax low-income measure was $53,140. $53,140. And for an individual, it's far less, right? It's $26,570. Most people don't really know what poverty looks like on a day-to-day basis. Being from Ontario, I'm going to use the Ontario Disability Support Program as an example. And I'd like to ask in a poll, and thank you, Lori, for finessing this for me. What do you think is the maximum monthly amount for an individual receiving ODSP? So that's the Ontario Disability Support Program. Is it $1,508, $1,320, $1,228, or $1,169? All right, do we have an answer, Lori? I can actually see it.
Oh, you can't see it. It is saying 35 of 52 people have participated. I can end the poll and it will show it on the screen. Shall I end it? Anyone else want to answer?
Final answer, everybody.
Final answer. Okay, let's end it and see what it says. Can you see the results?
Yep, thank you. Close, but not quite. So it actually is 1,228. So it's about 35% of us got that. And I really think that it's critical to consider, how small amount of money that is. So the Income Security Advocacy Center curates a lot of this data, and this is 2022 information collected by their group. It tells us that ODSP recipients must live on just over $1,200 per month. That's about $40 a day. When you do the math, this amounts to about $14,736 a year, well below the cutoff for poverty using the low-income measure. And so when you think about it, we're really talking about somebody who barely has enough money to survive. Now, there is some good news here. Based on data from the 2021 census, Stats Canada, using the low-income measure, the poverty rate in Canada was actually down to 9.3% from 14.5% in 2015. And these declines in poverty were driven largely by higher government transfers in 2020, specifically the temporary pandemic relief benefits like CERB, and the enhanced Canadian Child Benefit. And more good news, despite a popular belief to the contrary, income inequality in Canada has actually diminished in the recent years. And this is again due to the progressive nature of our income tax system coupled with government transfers to households. So I want to do a brief educational highlight here. The Gini coefficient is the most used measure of income inequality. So measured on a scale of 0 to 1, it calculates how much the distribution of income deviates from a perfectly equal distribution, that's 0, and that means everyone has the same income, exact equality, to 1, meaning one person has all the money, and that's total inequality. And so you can see here on this graph that inequality started to rise in the 90s and then stabilized in the early 2000s, and it's trended downwards since 2013. And this downward trend culminated in a large drop in 2020 when pandemic-related income supports, CERB, were created. And really what I want you to think about here and this idea to crystallize is this speaks to the power of universal income programs. And please remember this, and we're going to talk about this afterwards. So those particular supports are now over. Other programs that have contributed to falling income inequality, like the Canada Child Benefit, Old Age Security, and the Guaranteed Income Supplement, persist. However, the reality is that considerable income inequality still exists in Canada. We see large gaps in employment incomes between men and women, between top earners and most Canadians, between racialized people and white Canadians, and between Aboriginal and non-Aboriginal Canadians. So looking at the distribution of income amongst the lowest to highest income quintiles here on this graph, well, we don't see substantial polarization over time. There is still a large income gap between the highest on the right and the lower income quintiles. And again, income inequality is not uniform. Its effects are more profound for people with disabilities, women and children, racialized Canadians, Indigenous people, the LGBTQ2S, and the elderly. So I want to circle back to health here. Income inequality and health are inversely related. So you can see on the x-axis, income inequality is measured from low to high, with health and social indicators plotted from better to worse on the y-axis. And quite intuitively, we see countries with historically low income inequality, think of like Scandinavia, plotted on the left here, with correspondingly better health outcomes, while countries with more extreme inequality, like the US, have associated poor health outcomes. And health research further demonstrates this link between income and health outcomes. Age standardized mortality rates are lower for those in the highest income quintile for almost all causes of death, and then also for specific causes like cancer, metabolic illness, and HIV/AIDS. So now focus our lens a little bit more closely to addictions, as that is what we're here to talk about. So in the CMAHA 2018 publication, Care Not Corrections, they identify something that you all see and we all know, and that is that the opioid crisis disproportionately affects those living in poverty, those who are unemployed, and people contending with physical and psychological disability. And I mean, anyone who has worked on reserve or with Indigenous populations will note the increased rate of polysubstance use amongst Indigenous communities that are contending with intergenerational trauma, oppression, and systemic racism. So specifically looking at the relationship between income and opiate use disorders, in June 2022, a group of researchers at Waterloo published original quantitative research in the Journal of Health Promotion and Chronic Disease Prevention in Canada. So Al-Sabag and al. Explored the relationship between SES, or socioeconomic status, measured by income quintile, and adverse outcomes from opiate use in Canada between the years 2000 and 2017. And the results showed a stepped gradient from the highest income quintile to the lowest for opioid-related mortality, table 1, for hospitalizations related to opioid use, table 2, and opioid-related ED visits, table 3. And what's interesting to consider from these results and those that I showed you earlier for age standardized mortality rates by income quintile is that there is really no protective threshold for opioid use disorder as it relates to income. Certainly we see that with each and every step upwards in income, there are lower opioid-related outcomes in the quintile below, but there is still mortality, hospitalization, and emergency department visits for those at the very upper echelon of their socioeconomic status. So the authors suggest that a variety of psychosocial factors mediate this gradient. So what are these mechanisms at play? Well, first, what I want to say is what it is not. It is not access to prescription opioids by medical prescribers. And so this has long been blamed as a causal vector in the opioid epidemic. And as health providers, I remember even in my educational process, we were asked to reflect and to acknowledge our own role over prescribing opioids for physical pain as a source of the current crisis. And I think what that did is it actually helped us to actively participate in the solution in a rational and direct way, limiting our use of opioids for chronic non-cancer pain conditions and directing patients to opiate agonist treatment clinics and prescribing OAT when misuse was apparent. However, what it really did is it distracted us from appreciating the profound effect that social inequality has on human suffering. and the role that drug use serves in numbing the psychological pain caused by feelings of marginalization, discrimination, social isolation, and the absence of social capital, and the existence of trauma. And I'm sure that you see this firsthand in your practices. People who face a daily struggle to survive. Those who are contending with emotional, physical, and structural violence, and patients who battle internal struggles with mental health. And Dasgupta and al. Write that for these people, and I quote, opioid use treats a pain that is more than just physical, but a condition that includes economic and social disadvantage. And one well-worn groove in the pathway between poverty and substance use is stress. So stressful environment conditions, especially childhood trauma, can increase the risk of substance use. In a really excellent article by Nora Volkow called Addressing the Opioid Crisis Means Confronting the Socioeconomic Disparities, she highlights that poverty is a significant environmental factor that contributes to stress. And that's not only because financial hardship is itself stressful, but in the way that it influences other factors such as access to secure housing, nutrition, employment, educational success, and healthcare. Without the resources to address these issues, opioids and other drugs may be used to cope with stress. And we do see this firsthand when we look at the data looking trauma, adverse childhood experiences, and substance use disorders. We see that adults reporting 5 or more types of abuse are 3 times more likely to misuse prescription pain medications and 5 times more likely to engage in intravenous drug use. We see that adverse childhood experiences are associated with the development of chronic pain and addiction in later adulthood. And the experience of stigma and homophobia by LGBTQ2S youth is linked to their higher rates of substance use. So I'm just going to include this section really here with this quotation from Salovitz in 2016, who said, "Our response to today's opioid crisis cannot be effective if it ignores the socioeconomic aspects of the problem. Though advocates like to claim that addiction is an equal opportunity destroyer, in reality, it is far less likely to hit people who have stable, structured lives and decent employment than it is whose lives are marked by uncertainty and lack of work." So this is the meat. Let's talk intervention. Understanding that social determinants of health intersect to offer advantage or disadvantaged individuals means that we cannot invest our efforts solely in behavior change strategies. Now, this does presuppose that our patients have all the resources, motivation, and supports they need to enact change. And so we need to incorporate a social determinants of health lens into our day-to-day clinical work. And the great part is that one framework for this has already been developed, published by the Center of Effective Practice and available to template for almost most EMRs, is the poverty tool. Now, this is a simple 3-step approach that is meant to be used over a series of visits. And it directs us to use key questions to assess our patients' living conditions and current benefits, and then includes links to key government and community resources to support positive interventions. And so these 3 steps are to screen, adjust the risk, and intervene. Now, screening is only good if you do it. So the important thing to think about here is to ask everyone about poverty. The question, do you ever have difficulty making ends meet at the end of the month, has been validated and is 98% sensitive in identifying patients who are living in poverty. I mean, you may wish to reword this or tailor it for different cultures or languages or see what other types of phrases roll off your tongue. But the critical part is to ask everyone. You know, what's really beautiful about this approach is that it actually opens up a discussion. You know, we've learned from our palliative care colleagues that when faced with difficult conversations or content, patients wish to be asked directly and without judgment. And so you can build a social history, a patient social history over time, over several visits, in fact. I mean, working in addictions, especially in opiate agonist treatment clinics or RAM clinics, we have time. And as your patient's trust in you grows, which will be helped, of course, by your lack of judgment of their circumstances and your direct questioning, they are going to reveal the stories of their lives. And if you're looking for some guidance from the types of questions you might want to ask in a social history, you can reference the If It Helps tool, also available on the CEP website. And so you can see here, there's a number of different domains that are important to be considering when we're thinking about understanding a client's day-to-day lives and their social determinants. The second step in the poverty tool talks about adjusting risk. Now, this is something that we do on a regular basis in clinical care. For example, we use our knowledge of risk factors to guide our clinical decision-making. Knowing a client smokes certainly will impact how you investigate, say, they could have chest pain. So understanding the influence income has on health and addictions, consider how this might influence how you assess and treat your clients living in poverty. And third, and arguably the most important in the poverty tool, step in the poverty tool, is intervention. And what this entails is recognizing income inequality and leveraging those existing income equalizing programs for your benefit. I'm going to show you what I mean. So the reality is that not all patients are accessing the income support programs for which they may be eligible. And this might be due to lack of knowledge of the system, personal barriers to completing forms, such as intellectual disability, severe mental illness, or even being homeless. I always remember an example of a patient I had in practice at the Sherburne Health Center who had been on ODSP for the majority of his adult life and was living in a shelter downtown Toronto, and came to me in a panic about a month after he turned 65. He had no idea that he needed to apply for old age security. And when he turned 65, I think it was about a month later, and ODSP cut him off, his income went from somewhere, let's say around $1,228 to just over 400. So this was a really good learning experience for us at my clinic, because we started to flag individuals as they were at turning 64 to say, hey, look, let's have them meet with our client resource worker and ensure that they have the knowledge and the skills to do these forms. I also have a client of mine who had come to us after being a client of a different practice, and this patient had schizophrenia, but very well maintained. So, able to maintain her own health and well-being, and was securely housed. But she'd been on ODSP for probably 20 years and had no idea that there were income supplements, such as a special diet form for which she was completely eligible, or the mandatory special benefits form. Now, mind you, this is also the domain of her social worker, and I would have been happy had she let her know. But it's something that I'm always reminded of, and I make sure to ask my clients who are on ODSP. So that leads me to the next step, which is that the poverty tool really suggests a few short questions that can reveal which income support programs would provide your patients with the highest yield. And as we saw with the powerful income equalizing benefit of CERB, some programs offer really powerful assistance. So the first and arguably most important question here is to ask your patients if they have filed their income tax for the current year, and if at all. And I'm going to show you a graphic of just how powerful this is shortly. So further questions might include asking seniors, as we said, if they receive old age security, the GIS, and then gains. If your patient has children, making sure that they are receiving the universal childcare benefit. For Native, Métis, and Inuit patients, ask if they're registered under the Indian Act or recognized by an Inuit land claim organization. And then again, for those clients who are on social assistance, asking whether they have applied for extra income supplements. So I wanted to work through a bit of a case just to illustrate what this might look like in practice and how this might impact a patient. So Jason's a 58-year-old male who's attending your RAM or OATC clinic. He has a remote history of intravenous drug use with no sequelae in his health, and he developed his opiate use disorder following a motor vehicle accident resulting in chronic cervical neck pain. He's been in stable remission from his OUD on methadone 85 milligrams, and he receives full carries, but is really struggling to taper his dose due to his pain. And he's unfortunately failed several attempts to microdose onto Suboxone. He is divorced and he works part-time in construction. He supports 2 children, 10 and 6, for whom he has full custody. And he has recently moved to Toronto with his family from Woodstock to be closer to his extended family for supports. So the question is, how does poverty affect his life? So you engage with him on kind of a broader and deeper exploration of his social determinants. And so you learn that he has been working in construction part-time, and through that he earns about $14,000 per year. He lives in a 1-bedroom apartment with his 2 young daughters. monthly rent, which is market rent, is about $1,200. And he has not filed his taxes for years because he didn't think he owed anything. And so you recommend that he file his taxes and you refer him to a local agency that can support him to do so. And as a result, Jason receives about $19,000 in after-tax benefits. So this calculation, I just put through the Canada Revenue Agency tax calculator. So it's, it's not a guarantee, but it gives people a really strong idea of what they're eligible for. So you can see the breakdown here. Jason was entitled to the HST tax credit, child benefits, provincial benefits, and something called the working income tax benefit. So Jason was right. He didn't owe any taxes, but by not filing, he was missing massive benefits on top of his $14,000 in wages. So when you look at it, his annual income is now close to $33,000. Now this brings up, he brings him up much higher in the on the low income measure, but not quite enough to tip the threshold. I think if he'd been in a partnership family, then there would have been additional benefits. But as it stands, it kind of looks at one adult, one child. But the impact this is going to have on his life and his children's lives is really powerful. And I wanted just to show you kind of a general schema. This is a bit of an older chart. I haven't updated the numbers yet, but it shows the income equalizing effect of taxation and really up to about a pre-tax income of about $37. That's when it starts to kind of like plateau outwards. So with every step, when you start looking at the income after tax benefits and then after child benefits, it's really advantageous for people to do their taxes. Now, I think the challenge here is how to do this work, right? If you are like me and you're working in a RAM clinic or in a busy family practice, it may be really challenging to find the time to dig deep into these things. And that's why I wanted to go back to that idea of that longitudinal relationship that you build with your clients. But I also think that we need to start building up support networks. And so these key resources are actually included in the poverty tool. And so you'll see that these three that I mentioned include the Canada Benefits website, 211, which is variable throughout Ontario, and your legal rights. And I just wanted to make mention for people who are calling in from outside of Ontario. Sorry, I'm very Ontario-centric tonight. The poverty tool has been expanded to be eligible for almost every province in Ontario. Sorry, every province in the country. So if you look online to see your poverty tool for your province or territory, you will probably find one that has resources that are meant for you. And what I really like about these portals is they allow you to look at, what resources are available for you federally, provincially, and then locally with the 211. Your Legal Rights has been an extremely powerful tool for understanding the various income support programs, housing support programs, and advocacy programs for clients' rights. So if you have not looked at these websites, I strongly encourage you to do so at some time in the near future. And this process is just such an important tool. In a 2021 CMAJ article, Gary Block and Rosmovitz described how social interventions in poverty care settings, primary care settings, can mitigate the health impacts of adverse social conditions. So as we talked about already, this critical first step is the identification of social determinants, as we discussed, in the screening part of the poverty tool using the If It Helps mnemonic, and then using an established structured referral program. Providers connect patients to the necessary community resources to improve their social determinants of health. So this table identifies several interventions that are accessible to us as individual providers, small group practices, and then others that might need larger interdisciplinary resources. I also think where possible, it's important to network our addiction services to counseling. And I mean, I'm fully assuming that you're not already doing it yourself. You very well may be. The reality is that in addictions therapy, whether opioid, alcohol, stimulant, or other, we generally have the benefit of a longitudinal relationship, but our visits may often be brief. So I think it's important that we get a solid understanding of brief interventions for counseling as either standalone sessions, if you have the capacity, or done as part of any sort of clinical encounter, emerge department visits, RAM clinics, OAT clinics, primary care. And I've given a couple examples. Medify actually has some excellent resources. I was looking through them. I'm like, wow, look at this. It's tons of stuff on psychotherapy. So motivational interviewing, mindfulness. And then something that I happen to be doing right now is a focused acceptance and commitment therapy course, really brief interventions meant for 10 to 15-minute appointments to help move clients along the continuum of change. I also want you to think about how our actions as clinicians can influence a client's income security in our own practice. I've mentioned earlier, as addictions physicians, we are often a client's sole provider. And as such, we have a critical role to play in supporting income program applications. That might include employment insurance sickness benefits, disability program applications, and even, dare I say, the dreaded disability tax credit application. And then for those who are on disability programs already, we can help complete those supplemental forms that I discussed earlier, special diet forms, transportation forms that provide much needed additional income to offset costs for those needs. So we really need to be mindful of the barriers that we create. And just kind of on the topic of transportation, we need to think about how daily pharmacy attendance and customary weekly in-person visits for those on, say, long-acting opiate agonist treatment therapy programs influences negatively, potentially, clients' income and their ability to engage in meaningful action outside of their substance use. Understanding that the routine of daily observed therapy and regular clinic visits, we know that it provides clients with much needed structure in what can be a very chaotic life associated with substance use, but it can also pose a barrier to reintegration. And so I want to ask you to consider who you have maintained on this type of schedule. I'm reminded of a client who I've just recently actually assumed their methadone prescribing in my family practice, quite interestingly, who was diagnosed, about 12, 13 years ago with ankylosing spondylitis. And through that process had developed an opiate use disorder, but stabilized pretty quickly on methadone, has been on a stable dose of methadone with full carries for about 6 or 7 years. And when I took over her care, it was because she had continued to be required to attend her OAT clinic weekly and provide urine drug screens, despite not having any aberrant substance use in, as I said, over 6 or 7 years. I wanted you to think a little bit about scheduling. I know that many of us in rapid access clinics operate already on an open access or a same-day appointment scheduling model, but many do also have limited hours, which can pose a barrier to those who are trying to work to support their families. So I think it's just interesting to consider where that plays in. And then I was just having a reflective moment today after visiting my own pharmacy, thinking about how important it is for our pharmacy colleagues to consider whether we can massage some of the costs to our clients. How can we reduce dispensing fees, especially for those clients who are on social assistance or who are otherwise financially vulnerable? Can you advocate to the clinicians, to the prescriber, to increase dispensing intervals? Instead of having the client come back once a month, could they come back every 3 months? Of note, I know that in Ontario, the Ontario Drug Benefit Formulary will allow a maximum of 100 days of prescription dispense. So if we are giving people less, we are requiring them to come in for transportation more than they need to. And then, of course, I know that one of the things I've always carried on with my pharmacy colleagues has been their supportive, their work in doing Trillium applications for those who don't have drug insurance coverage for medication. So I just want you to think a bit beyond the patient. So this is our call to action. The College of Family Physicians of Canada urges us to think beyond the patient in front of us and to use our power and knowledge to address social determinants of health. So now we have already explored ways in which we can influence change at this micro level, but it's also important to reflect on how we might improve social determinants of health at the meso and macro levels. So the meso refers to changes and improvements at the local community level, while macro refers to the broader impact through healthy public policy. Actions at these levels are predicated on health advocacy. So some examples of meso-level interventions could include providing experiential learning to medical learners on the SDOH. Another is to establish a relationship to your local MPP to better understand how SDOH and social determinants influence in your community, and provide leadership and influence change at the community level. A macro level intervention could be to join an existing advocacy group that takes a stance on social determinants of health. And you know, there's a ton of advocacy efforts that are supported by physicians. They're numerous. They include advocating to increase minimum wage, establish Medicare, improve living conditions for migrants, reduce social exclusion due to racism, transphobia, homophobia. So there's so many opportunities to be involved. And just thinking about this as it relates to opioid use disorders, you can see here that there are specific ways in which we can use this lens and note areas of intervention for opioid use disorders. So that inner individual factor, those are the individual personal relationships that you have with your clients. But then there's interpersonal, there's community level interventions, and then there's those cultural and broader interventions. And really the major risk factors of opiate misuse are shaped by these larger contexts, which encompass opiate supply and demand, government regulations, economic conditions, unemployment rates, elements of the media, social stigma, discrimination and prejudice, advertising campaigns, educational campaigns, and law enforcement. So if you're feeling like things aren't changing at the micro level, maybe it is time to expand your lens to the meso and the macro level and see where you can influence change. So I think with that, I've come to a close here. Just reviewing the things that we've talked about tonight. We've reviewed the impact of income on health. We've examined the arguments for intervening in poverty and addictions medicine. And then I have demonstrated how we might use the poverty tool in family practice and addictions practice to influence change. And I'm going to close with that. I'm going to stop sharing and we can have a chat.
Wonderful. Thank you so much, Larisa, for that really interesting and engaging presentation. The chat has been quiet, and I'm assuming that everyone's just saving their questions up till now. So one of the early questions that came in was from Mike Franklin, which asked if you can talk about the minimum income program that was canceled by the current government. It made a huge difference to my northern patients and helped several out of addiction.
I'm curious, Mike, are you in Ontario? If you don't mind unmuting. Or are you elsewhere? I
don't know if Mike can unmute or not, but
that's okay.
I happen to know that he's in Sudbury. Hi, Mike.
Okay, well, so I think what Mike is referring to is so there's two parts to my answer to the question. So there was a minimum income project that had been started in the 1970s in Manitoba, commonly or colloquially referred to as the MINCOM program. And it really looked at whether or not providing individuals with a basic living wage, so a minimum amount of money every month, regardless of their financial status, would help to kind of equalize these adverse social outcomes. And unfortunately, the program did not succeed. It was a trial, but it was not adopted either at a provincial level or a national level. And what I think Mike is talking about is a minimum income project that was started here in Ontario with a certain amount, like a small number of satellite sites that unfortunately was canceled by Doug Ford. So this is a huge thorn in my side. When you think about what happened in 2020, if I could go back to those slides of the income equalizing effects of our universal income programs like CERB, the Canada Child Benefit, we did see that income inequality dramatically changed, and poverty rates also changed. So there have been many questions around, what would be the outcome of this, and what what this might look like structurally. So imagine when we think about what a minimum income program might look like, would be that every single person, regardless of their income level, over the age of 18, adult level, would receive a certain amount of money per month, one that would typically give them enough to live at that low income, like poverty line. So just at that threshold. And the supposition would be that if you subsequently went off to make more money and wanted to make more income, then you would repay that or pay that back in your taxes. And so you can see the impact that that would have. Number one, it could potentially collapse all existing income security programs underneath it. So that would be no ODSP. We wouldn't need disability programs. And I think about all the red tape and the hardship that I go through sometimes to get through to like workers. And I wonder whether, that would be it would be a success. But again, I think the reason why those programs have not been maintained, I'm surmising that it might be the risk of losing those jobs per se. Like that's a lot of work in the public service. But I don't also know, Mike, exactly why it was discontinued. But this is a big area of advocacy, right? So this is something where, as clinicians who work with individuals who are living in poverty, this is a really big place that we could advocate. I'm looking to see some more questions here.
Yes, there are lots of questions now coming in. One comment that I wanted to from Robin. I know the folks who developed your legal rights, and they will be delighted to hear they were mentioned as very useful. I'll let them know. So that's good. A question from Gail Parker. I have a question. I have a patient who is now getting his ODSP cut by $400 per month to pay back his CERB payments. Is there anything we can do to appeal this?
I'm not certain I can answer your question, Gail. I don't know. I also wonder about I don't know that clients. I think the problem is that there may have been some double dipping, right? So I think that there's a concern. I have a client right now who is living with her partner. She is on ODSP and is intermittently working, but not full time. Her partner was working full time, but has gone on sick leave. And we were exploring, what options there might be to support him. And I suggested, hey, you worked for a while. Why don't we claim EI sickness benefits? And unfortunately, because they're on a couple's plan, any income that he receives goes and detracts from their eligibility for their ODSP funding. So I think the reality is these systems are mutually exclusive, right? So you can't get one and get the other. I also know a client of mine who received CERB and worked and collected social assistance and is now in arrears. So I think the best thing to do would be to contact, your legal rights and seek some sort of legal advocacy for them, which is tough.
Yeah, I'm just giving my own commentary now, but
Please.
There seems to be such everything that all of the benefits that are set up for our healthcare system. There is this underlying fear that someone is going to get something that they're not entitled to, and that this is the worst thing that could possibly happen. And it seems so ludicrous to me that people who are struggling, that there's this sort of nickel and diming. And of course, I don't actually know what I'm talking about, and all the everything that is behind it. But it just seems like such a lot. So much is put in place to. It's framed as making sure that there's no abuse of the system. And that doesn't feel to me like that should be the primary concern.
Well, and I think to your point, Sarah, that this would be made a lot more simple if there was just one single program, right? As opposed to multiple different programs of different eligibility criteria. If we were all universally eligible just by nature of being humans and citizens of Canada and Ontario to a certain amount of money per month, that would raise us out of poverty. And there would be some people, as there are always, who would be content to live on this. And I think this goes to your point around, and also I wanted to say to Gail's point around how, addiction causes poverty because people spend all their money on drugs. Well, if not everybody wishes to live at or near that poverty line, some people can. Some people cannot move past that for whatever their reasons are, whether it's disability or trauma or a lack of motivation. There are all different types of people. But the reality is if, nobody wants to live under the poverty line. That is for sure. Living on whatever we talked about before, on ODSP, $1,228 per month. That's not living at all. That's barely living. And that has to include your rent and your food and your clothing and your transportation and everything. And so I think you're right. There's a lot of nickel and diming in the system right now, and that is because there are multiple payers as opposed to one single payer.
Yeah, that is a point that Noam in the chat has also. I agree. It would be much nicer and more straightforward if there was one single program that helped people figure out what their entitlements are, and also linked assistance wages with inflation, which is another great point, I think.
Oh yeah, I mean, if you go back, once the slides circulate, if you go back and look at the income security assistance slide where it talks about the different ODSP, I downloaded that. Clio, which is another community legal aid organization, they provide updated information on ODSP and OW rates in Ontario on an annual basis, and they say that they simply have not kept up with inflation. This is again like the third year in a row where ODSP rates have gone up minimally, if at all. I'm going here. So
Tomoko Fukushima made a point
Hi,
about patients saying that they're doing well, but you ask if they're using the food bank and they are relying on it. And also the point that there are undocumented residents who don't have access to OHIP and social assistance, and so end up living in poverty without even those aids.
Tomoko, I'm just wondering, I'm curious to know what resources you've been finding to support those undocumented residents in Ontario, because I think that's where we really are relying on so much on donations and support programs, because there really is minimal income support.
Tomoko, I think if you raise your hand, we can unmute you. I think that's how it works. Sorry, we're still figuring out our new webinar setup. Or of course, you can just put it in the chat.
Yeah. There was another point that I wanted to see. Oh, hey, Tomoko, go ahead. Oh, can I just talk? I was going to talk. Oh, go ahead, Tomoko, you go ahead, please speak.
No, you're right. I was just going to say just donations and or they go precarious work environment where it's like under the table working environment, and that's how they fund their residents here.
Thanks, Tomoko. I want to respond, Leonard, to your point, because this is something that I for sure we see. Like, there is no question that there are always going to be individuals who are taking advantage of the system. And the best answer I have is this: we have an intermediate supportive social network system for income. It's not the same as Scandinavia, where there is a lot of income equality, more income equality, but there is some here. And I think that when you have a system like this, where we universally support individuals who are living low income or who are disadvantaged in some sort of way, you have to assume that there is going to be a percentage of those individuals who are going to take advantage of the system. And the alternative to that would be to go into a model like we have in the US, or there is in the US, where everybody is out for themselves and they have to purchase their own benefits, and it is, every man for themselves or every person for themselves. Yeah, it is always difficult for me to watch individuals who are taking advantage of the system, but I think we have to accept that as part of it and recognize that there's always going to be a few people who are manipulative and who are going to game the system if we want to have a system at all, right? So you can't have a supportive system and make everybody 100% accountable. It just doesn't work like that. Like, That's humanity. And so I try to just dispel and quell my like anger and upsetness about those individuals and really invest my time in the ones that I think are really at need and who are probably not getting and taking advantage of the system. So it's not, it doesn't make it better. But it maybe allows me, it gives me a better sense of understanding. I don't know if anybody else has that idea out there.
There are some responses to
Yeah.
to this.
Oh, this is great. I like the debate here. You know, I mean, and it's true, Katie. I agree with you. I think that if needs are being met, that people wouldn't take advantage of the system. But that at the same time, there also are individuals for whom, like, there are sociopaths and there are manipulative individuals out there, no matter what, whether they're capitalists or they are not. So I think we do need to be mindful of that element of humanity, right? You know, we have, if there's going to be 20% of the population that is on social assistance, you know, there are going to be some that are potentially manipulating it, but then there's some who are not. Thanks, Tomoka. That's as well said. We can't worry about the 1% of misuse and ignore the 99% of people who are starving.
I don't know if you addressed this comment specifically, Larissa, but Katie also added people would need to take advantage of the system if their needs were being met.
Yeah.
So and that's a really, I think, a really valid point.
Yeah. So just scrolling up here. Thanks, Jennifer, for your comment around if we don't have a guaranteed minimum income, some guaranteed fixed housing pricing would be very helpful. Definitely, we do not have enough housing. Leonard, just to also answer your question, the poverty tool does integrate with EMRs. In fact, if you go to the Center for Effective Practice and the OCFP website, you can download it and integrate it into a number of different EMRs. I just can't remember which ones. I know Ocean is one of them, and there's a few others as well. And for the person who wrote that lovely S-Kemp, thank you very much for the comments. It's really great. Very lovely commentary. Appreciate that. I mean, I'm also happy if individuals want to chime in and talk about the things that they've been doing in your community that you think have been beneficial. There are tons of examples of community-based programs that are really picking up the pieces where our social network is not in place. That I don't think that I've really encapsulated all of them in this presentation today. So if there's others, if anybody else wants to comment and chime in, please come on. This is a great opportunity.
Your whole presentation, Larissa, I've been trying desperately to remember. I've just finished taking a health policy course, and we have been talking a lot about how health care is funded, and what is the role of different parts of, do we actually have universal health care? What is actually covered under that? And I've been trying to remember the type of program that I read about where the other levels that you were talking about. So looking beyond the level of the individual, that sort of explicitly incorporated into the healthcare model. And of course, I can't remember, and I'm too flustered to look it up right now. But it is a topic that I think deserves a lot of attention. And what is the healthcare is much broader than not, and I don't mean to dismiss the importance of prescribing and of diagnosing and all of the functions of the healthcare system that is funded. But health is such a broad category, and as you've shown, it touches so many. There are so many factors that contribute that go far beyond the individual.
And we really have a unique position as physicians, because we have a voice that people want to hear. I mean, wait, hold on a second. I would have said that probably a bit more before the pandemic, and then after the pandemic, I feel like everybody just wants to look things up on the internet, but I'm just being jaded now. That was my old jaded joke. We as clinicians have a very valuable voice, and people really want to hear it. And so again, going back to the idea of what things you can do just even at that meso community level to connect with your MPP, it's something that I'd never thought of. until actually my own family had healthcare issues, and we were struggling with how to make changes happen at our local community hospital. And that was the step we took, and it was extremely impactful. It's really unique to think about how politicians they're looking for campaign platforms sometimes. And if you can put your ideas on their agenda, then that is a massive move, right? So there's that, then there's the educational piece that we can provide that experiential learning to upcoming residents, medical learners, interns, nursing interns, pharmacy interns, and really show them what it's like to work with this population.
Someone has commented on CAPC, CPNP programs. I don't actually know what those are, but these programs can be super helpful for families with young children.
Margie, can you spell out those acronyms for us? Let's see.
Action program.
Community Action Program for Children. Oh, I will have to look that up.
There's a comment from Britt. I find it challenging to be as flexible as I want with OAT prescribing and dispensing in the RAM context. In my family practice, I can do what I want, but if I want someone else to eventually take over clients' OAT prescribing, and it's hard to have them pick up meds Q2 months because nobody will ever take them over.
So I think, Britt, you're kind of referring to almost like a business model in essence. Am I right? I don't want to assume that I know the underlying comment there. All right. I'll I think great. Yeah. So Britt, so I'm just trying to figure out the your point around this is that, sorry, so Britt, you did want to talk to everybody, is that right? We're looking through the chat here, guys.
Yeah, sorry, sorry, go ahead, Britt.
I think Britt has been taken over by Chipmunk.
No, I don't think that's,
Gosh.
sorry.
That was pretty impressive. Nope, still not working, Britt. Unfortunately.
Your audio is extremely garbled, sorry.
If you get a chance, Britt, you can pop it in the chat. It's okay.
Sorry, I'm not sure what's going on. Oh.
So Margie's put a couple different things here to expand on those programs. And then Robin added, great, thank you for putting those in, Robin, the link to the programs.
I mean, I can start framing what I think Britt is meaning, and hopefully she'll correct me in the chat if I get it wrong. But if the intention is so the model of the RAM care is ideally it's a short-term model where people get stabilized and then transition back to community care with their primary care provider. But if someone has a standing script that is, pick up every 2 months, that will be a hard script perhaps to get someone else to take over. Is that?
I also think that the difference in in prescribing practices probably is more relates more to stable patients, right? So I don't want to take away that aspect that I said around the structure and routine that is inherent in many RAM clinic models, in many opiate agonist treatment clinic programs, where clients are really exiting out of a very chaotic lifestyle, and the daily pharmacy visits and the weekly RAM clinic or provider visits, whether they be virtual or in person, serve a really important function to anchor those new patterns of behavior. So I'm not suggesting that we take people who are unstable and give them 2 months prescriptions, but that we do so when clients are able to manage that. And I mean, even in some of our, like in our OAT clinic, we've been exploring, for clients who are extremely unstable and who are frequently on and off the program, whether providing them with a 1-month prescription that says, just keep at one stable, like one low dose that is an entry dose, regardless of whether or not the client misses doses. And if they are able to get some stability into them, then they can come to the provider and up it. But we're recognizing that sometimes the barrier is actually just getting into the clinic. And I mean, I think everybody who works in a RAM clinic knows that, is that like there's a huge chance your patient's not going to come back. And so whatever we can do to support that, through prescribing practices, through dispensing practices, is probably advantageous to the client.
See, we have some hands up. Leonard Bienenstock has a hand up. Can you unmute yourself, Leonard?
Unmute. Hello.
Hi.
Hi.
Yeah, I mean, I got cut off in the chat when describing my question, but I don't want to. It was essentially, you answered it already. It was about reconciling pros and cons of any support program, and how 99% of the time I fall on the side of more resources and advocacy. And it's a pleasure and an honor and a privilege to do that for clients. And I know how much it matters. And 1% of the time, it's obvious misuse of the system. And I find that troubling, and it frustrates me and upsets me and makes me angry, and I'm a human being and I have feelings too, in addition to my profession. And I asked how you personally reconcile, those circumstances, and you did, in saying that, there is no leaky bucket that doesn't leak, and on the whole, it's worth it. And I would agree with that, but just acknowledging that it is frustrating makes me feel a bit better, and that I'm not alone.
Absolutely. Thank you for coming in and chatting. I think sometimes when you put yourself out there in the chat and it goes a little bit awry, then it can be difficult to come back in. But I really do value that comment, and that is what these arenas are for, is to have these kinds of like-minded observations and discussions, and really feel that we are not doing this on our own. That you are not the only person that does not get incredibly frustrated with the person that has asked, for the umpteenth time for a prescription for something for which that they may not be using. And but yet, as one of our the comments as well, Katie said, if we had a better system, then people wouldn't have to game it, ideally. So there's both those two sides, right? Empathy 100% for you and your experience, and ours as well.
Kudu has a hand up. Can you unmute yourself?
Most of my statements have been already made, but I agree. If the system has not put in place strategies that really limit and almost banish those individuals, I don't think there will be too many people trying to find workaround. I recently had a client who was evicted, became homeless, and we tried to seek like the Ontario funded housing lodging for him. And one of the rules is that he has to finish everything he has in his pocket before they can pay for him. And his lodging money was not like pay forward, like it was not like pay the next month. It was pay after you finish the month. So he basically paid off the lodging home that just kicked him out. And then he had only his food money, but he has to rent a motel for 2 nights to finish his money before he can get help. So like rules like that are really, really horrendous and inhuman, in my opinion. So like, how can we advocate, like from the system level, to make changes to those? Like, these individuals are suffering. Like, honestly, if you have to spend how much money they have for rent, food, everything, I know I can't survive 1 week.
I fully agree that is a cruel and completely unacceptable policy. Huda, did your patient eventually go on to be housed?
They put him in a lodging home, but he has,
Mhm.
they didn't put him in a lodging home. They put him in a motel, but they don't offer food either.
Mhm.
Yet they challenged him to finish his entire month's food money for 2 nights.
Mhm.
So now we are paying for his food, you know, getting,
Right.
you know, giant tiger gift cards and things to give him daily so he can buy the necessities rest of the month.
Mhm.
But like, who makes those rules? I have no idea.
Yeah, and I think the sad part is that if we pulled everybody in, at least at this presentation, if not more others, then everybody would have these stories of individuals who have really suffered, you know, at the hands of inappropriate housing policies, eviction policies, income security policies. And so this is again where, you know, I challenge all of us to find that issue that really moves you, that really, you know, draws you, that you want to stand up and because these kinds of stories, Huda, are so meaningful, right? If we lend our voices to if we tell our clients stories, because the hard part is like nobody's listening to them, right? We are listening to them, but the rest of the world is not listening to them. To the rest of the world, they are people who are unseen, who are of no value. And so this is where we really can bring their voices to light. And when we collectively do that, then we have much more power. So thank you for your comment.
Thank you.
I'm just reading. Thank you for, oh yes, take the clients with their stories with you. Absolutely. Thank you. Yeah, that's a great idea.
Great point.
Yeah. Jennifer is making mention of a members bill in Manitoba regarding guaranteed livable basic income. Amazing. Excellent. Yes. Yes. Let's all do that. Everybody write that down. Let's see thank you, Noam. Although Noam, you just send it to the host and the panelists. You have to send it to everybody. Can you send it to everyone?
There's a setting you can toggle in the chat box. It goes between everyone and hosts and panelists. So if you want your message to go to everyone, make sure that's set to everyone.
Thanks, Noam. I'm excited, Jennifer. I'm totally gonna write my MP. This is great.
I think it's really important that you acknowledged all of the like the barriers that are in place to doing the things that I'm sure many clinicians want to do for their patients and their clients, and like the paperwork forms and all and like just thinking about things like transportation and acknowledging how much of an additional that is a barrier for many reasons. And I think it kind of speaks to the importance of sort of team-based practice in some ways, and ensuring that, you know, that these things are important, and it's not that, you know, a physician has to do them or someone with a particular, you know, role has to do them, but they have to be done. And it's important, I think, to you know, value that work and ensure that work that work is sort of incorporated into the practice.
Yeah, thank you, Gail, 100%. How much more time I would have to not do these. Yeah, I think thanks, Noam. I think also the whole process of applying for disability, and I imagine that anybody who has witnessed clients walk this path of like being on welfare for, you know, X many years until their OW worker in Ontario, their welfare worker says, hey, you know, you've been on welfare for, you know, 5-10 years. You should apply for disability. What is that? That is medicalizing poverty. You know, that's saying, you know, that you have not been able to get work, therefore you must be disabled. And maybe they are, maybe they are not. Maybe they simply have been oppressed by the various, you know, other social determinants of health that limit their access to stable income and housing. So there's a disabling process by which people go to, and it is so demoralizing to watch that person come to you and then have to prove that they are disabled. If there's something that makes people disabled, it's applying for disability. I wanted to comment on one other thing that I saw. Oh, yes, thank you. Oh, I can't remember now. It's lost me. I've lost it.
Was it about this report? So Noam sent this report done by a lawyer checking why UBI is good fiscal policy from a legal perspective.
No, but I'm really going to read it.
Yeah.
Thanks, Noam.
Yeah.
I think we have just a few minutes left. I'm more than happy to continue chatting, or if people are inspired to go home and write a letter to their MPP. You know, it doesn't take long. To their MP, not their MPP, their MP.
Yeah. Please, if folks have more comments, please raise your hand. Please put them in the chat. Yes. Thank you, Lori. Yes. After you've written your MP, the survey for this session, we really do appreciate your feedback. And again, if you miss this, oh no, I'm getting a podcast link. If you miss this link to the survey, don't worry, there will be other chances to pick it up. So you'll have a chance to give your feedback. Oh, thanks. As I said, Jennifer will be back next month, so you'll have a slightly less chaotic.
You were great, Sarah.
Oh, thanks. It's you know, I'm at these webinars every month anyway, and it's, you know, it's nice. Oh, here's the Ladies Who Crunch. Good name.
It's good.
Oh yes, thank you, Jennifer. So it's National Framework for a Guaranteed Livable Basic Income Act.
Beautiful.
Is on. Great.
Well, thank you everybody for your active participation tonight. Really appreciate it. And for being such an amazing resource to your clients. You know, I know that you're probably here for a reason. So just keep spreading the word and doing the good work.
Thank you for that, Larissa. And yes, thank you everyone for coming. Thank you for the work that you do. Thank you for engaging this evening. And next month, I will just put in a plug for next month. Webinar on March 8th. It's called Standing Strong Together, Mashkowiga Buida, a toolkit for Northwestern Ontario RAM approach. And our speakers will be Pia Heikkinen, Denise Forsyth, and Shannon Moore. So please come to that. And again, thank you all so much. Thank you very much, Larissa, for your time and sharing your expertise with us. We really appreciate it.
Thank you, everybody. Thanks for all the comments. Really appreciate it. You're too nice.
Thanks, everyone.
Bye.
Bye.